OSP meeting.
conference will now be recorded.
Well, to start off, I'd like to call Hafiz Mobile for Tilawat, and then we will carry on from there.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم وقل جاء الحق وزهق الباطل إن الباطل كان زهوقا وننزل من القرآن ما هو شفاء ورحمة للمؤمنين ولا يزيد الظالمين إلا خسارا وإذا أنعمنا على الإنسان أعرض ونأى بجانبه وإذا مسه الشر كان يئوسا صدق الله العظيم.
Mashallah, thank you, Mobile. Next, I'd like to call upon our ever dynamic General Secretary of the OSP Lahore, Dr. Nasir Chaudhry Saab, please on stage.
Bismillahirrahmanirrahim. Thank you very much, Faisal, for the kind words. This is indeed great pleasure to be here, and I would like to extend my deep gratitude to Honorable and worthy Chairman Department of Ophthalmology, Al Ali Medical College, Professor Dr. Mia Arshad. He's a great teacher, surgeon, and true academician. And then we have a class, young and passionate assistant professor, Dr. Tahir Ghaffar, and followed by a long list of young adult learners. We are well aware of the fact that OSP Lahore has a huge role in uplifting academics across the country through its time-to-time scientific sessions, symposia, these clinical meetings, in addition to annual big scientific session in the form of international conference, which is at par with the international guidelines and suggestions. So these clinical meetings basically serve as a role of purpose of formative assessment, in fact, because it allows you to reflect your weakness and then reflect the after reflection you can refine your weakness, improve your clinical knowledge, skill, and attitude for the upcoming summative assessment. So these are the greatest source of feedback on the basis of which you can define your skills. So OSP Lahore has the tradition of awarding certificates, shields, and cash prize to the first three presenters of the clinical meeting. In that regard, I would like to request Professor Dr. Salim Akhtar Saab, Professor Dr. Ahmad Bhatt Saab, Associate Professor Dr. Amera. They will be the judge for these presentations. And in the meantime, I would be grateful, and I would like to extend my heartiest gratitude to all those who have joined us physically and through online. And now I would like to request Faisal again for the further proceedings.
Thank you, sir. Now, before we wait for any longer, let's start off with our first presentation. I'd like to call upon Dr. Zara to please come and present your first case.
Assalamu alaikum. I, Dr. Binti Zara, PGR Ophthalmology, Gulab Devi Hospital, Lahore. My patient, XYZ, 29-year-old female resident of Gujranwala, a housewife, came via OPD with blurring of vision and complaint of linear image appears to be distorted, metamorphopsia from 6 months. Blurring of vision was gradual, painless, progressive in nature in both eyes, but more on the right side. She is using minus 3.25 diopter glasses for last 5 years. No history of laser, no ocular drug history, no injection, no surgery, no trauma. No significant medical, surgical, and family history. She is married, having 4 children, and belongs to middle class family. On the physical examination, her pulse was 82, respiratory rate was 18 per minute, BP was 130 by 70, temperature was 98.6 Fahrenheit. On ocular examination, extraocular movements are full, RAPD was negative, regurgitation test was also negative. Her visual acuity was 6 by 60 in the right eye and 6 by 36 in the left eye. Best corrective visual acuity with minus 3.25 diopter lens is 6 by 24 in the left eye, but there was no improvement in the right eye. Eyelids and conjunctiva are normal. Cornea are clear. Anterior chambers are quiet and deep. Lens are clear in both eyes. Intraocular pressure was 12 millimeter of mercury in both eyes. On systemic examination, there was yellowish papules at the lateral side of neck, elbow, and the lower abdomen. This is the fundus picture of the right eye, showing the grayish lesion at the level of macula and the gray lesion around the optic disc extending to the periphery and joint streaks. Similarly, this is the photograph of the left fundus showing the grayish lesion around the optic disc and extending to the periphery and joint streaks. CD ratio was 0.2 in both eyes. Vessels were normal, no reticular dystrophy, no macular degeneration was seen. Now our DDS was angioid streak, reticular dystrophy of retinal pigment epithelium, wet age-related macular degeneration, macular cracks. On further investigations, some systemic investigations were done, like complete blood counts, peripheral blood smear, LFTs, RFTs, serum alkaline phosphatase, HbA1c, and chest rays. All labs were normal. X-ray was normal, and labs are within normal limits. There was no significant finding. Now, the OCT. The OCT shows the loss of ellipsoid zone and interdigitation zone with subretinal hyperreflective lesion. Here you can see this is the right eye, now on the left side. With macular thickness. Now, this is the late phase of FF showing hyperfluorescent and hypofluorescent area at the level of macula, which shows the leakage. And these arrows showing the angioid streaks. And this is the left eye. Similarly, here we can see the hyperfluorescent with the hypofluorescent area at the level of macula, and the arrows are showing angioid streaks. Now, our diagnosis was bilateral angioid streaks with choroidal neovascularization. Our multidisciplinary approach was dermatological evaluation and cardiologist evaluation. Dermatological evaluation was done and the patient was evaluated as the case of pseudoxanthoma elasticum. Cardiologist evaluation was also done, which was normal and there was no significant findings. Now our treatment plan was left intravitreal anti-VEGF. 3 anti-VEGFs were injected with uh, within one dose in 1 month. And now this is the follow-up picture of the patient after 3 months. As you can see, the condition is improving. Now this is the OCT. Now on follow-up, ocular examination was done. Visual acuity was improved in the left eye. Visual acuity was previously was 6 by 36, which improved to 6 by 24, and best corrected visual acuity was 6 by 24 previously. Now it improves to 6 by 18. Eyelids and conjunctiva are normal, cornea are clear, anterior chambers are quiet and deep, lens are clear, and intraocular pressure was 12 millimeter of mercury. Here, some literature views are added about angioid streaks, pseudoxanthoma elasticum, and their treatment with CNV. Now, what are angioid streaks? Angioid streaks are crack-like adhesions in the brittle, thickened, and calcified Brooks membrane associated with atrophy of the overlying retinal pigment epithelium. On histopathology, they are microscopic features are characteristic and reveals fragment and distorted elastic fibers in the Brooks membrane and the reticular fibers in the dermis. Here we can see the cracks in the Brooks membrane and abnormal vascularization. Now, what are the causes of the angioid streaks? Angioid streaks may be caused by idiopathic pseudoxanthoma elasticum, Paget's disease, sickle cell disease, hypercalcemia. Ocular findings of angioid streaks are visual acuity normal unless there is leakage, bleeding, or Brooks membrane dehiscence involve the central retina. On fundus, linear gray with irregular serrated edges lying beneath the normal retinal vessels. Intercommunicate in ring-like fashion around the discs extending to the periphery. Purity orange or leopard skin spotting, peripapillary chorioretinal atrophy, focal peripheral chorioscar, Salmon spots, reticle pigment dystrophy of macula, optic nerve hydrosen. Complications of angioid streaks may involve CNV, choroidal neovascularization, subretinal hemorrhage, macular degeneration, retinal detachment, and optic disc drusen. Now, investigations for angioid streaks are optical coherence tomography, iridocynin-green angiography, fundus fluorescence angiography. Angioid streaks are managed by laser photocoagulation, photodynamic therapy, anti-VEGF therapy when CNV is developed. Now, as we know that the patient is also diagnosed with pseudoxanthoma elasticum. Now, what is pseudoxanthoma elasticum? Pseudoxanthoma elasticum is a rare progressive disorder characterized by calcification and fragmentation of the elastic fibers, affecting primarily the skin, retina, and the cardiovascular system. Now, there are some major and minor criteria to diagnose pseudoxanthoma elasticum involving the skin, eye, and genetics. On the basis of skin, the major criteria involves pinch papules or plaques on the lateral side of the neck or flexure areas of the body, or increased of morphologically altered elastin with fragmentation, clumping, and calcification of elastic fibers in the skin biopsy taken from clinically affected skin. On the basis of the eye, major criteria involves purity orange of the retina or one or more angioid streaks, each at least as long as 1 disc diameter. When in doubt, fluorescence or either indocyanine green angiography of the fundus is needed for confirmation. In minor criteria, one angioid streak shorter than 1 disc diameter or one or more comets or wing signs in the retina. Major criteria on the basis of genetics: a pathogenic mutation of both alleles of the ABCC6 gene or first degree relative, parent, sibling or child who meets independently the diagnostic criteria for definitive pseudoxanthoma elasticum, and minor criteria involves a pathogenic mutation of one allele of both of the ABCC6 gene. Now, thank you so much. Any questions?
Thank you, Dr. Zara. Next, I'd like to call upon Dr. Akib to please present his case.
Bismillahirrahmanirrahim. Assalamu alaikum everyone. My name is Dr. Akib Ardalan and I'm a PGR of ophthalmology in Gulab Devi Teaching Hospital. My patient XYZ is a 59-year-old male, a resident of Shadra, Lahore, a shopkeeper by occupation and admitted to us via OPD. He presented with a complaint of gradual decrease of vision in the left eye for past 18 months. He had blurring of vision in the left eye for 18 months, which was painless, gradual in onset, and progressive in nature. He also complained that the objects in front of him appears to be smaller than normal, and the linear objects such as lines appear to be curvy or rounded. And he also had some visual disturbance with the light source. Now, he was a type 2 diabetic for past 8 years and already on oral hypoglycemic agents. He had bilateral cataract surgery done 1.6 years ago. He had that surgery from the peripheral area, and after the surgery, he started having these complaints, which did not improve. Then he had multiple visits to different doctors, but no proper ocular investigations were done. He is a smoker, a non-addict, belonged to a middle-class family, having 5 children, and his father was also a diabetic. On general physical examination, his pulse was 84 per minute, the blood pressure was 130 by 70 millimeter of mercury, and the respiratory rate was 16 per minute, and his temperature was 98.6 degree Fahrenheit. Now coming towards his ocular examination, his visual acuity in the right eye was 6 by 12, which further improved with the best corrected visual acuity to 6 by 6. But in the left eye, his visual acuity was 6 by 36, which did not improve with the best corrected visual acuity. The extraocular movements were full, lids and conjunctiva were normal, the cornea was clear, and the anterior chamber was quiet and deep in both eyes. On lens examination, he was pseudophakic bilaterally, and the intraocular pressure in both eyes was 12 millimeter of mercury. Now, here is the fundus photograph of his left eye. As we can see, there is altered foveal reflex. On examination, his cup disc ratio was 0.4 and the vessels and periphery was normal. So we made our differential diagnosis so far were vitreomacular traction, pseudophakic cystoid macular edema, epiretinal membrane, and other causes of cystoid macular edema such as diabetic macular edema or macular telangiectasia. We started our baseline investigations, and as we all can see, they were quite in normal range except the HbA1c, which was a bit higher. Now moving towards his ocular investigation, and the investigation of choice we had was optical coherence tomography. Here's a picture of his left eye OCT showing vitreomacular traction causing macular edema, but it was not associated with macular hole or epiretinal membrane. And we made our diagnosis, which is left vitreomacular traction syndrome. And we plan the treatment for left pars plana vitrectomy with internal limiting membrane peeling. After the successful vitrectomy, the patient came back to us 1 week of follow-up, and this is the fundus photograph after 1 week. This is the OCT of 1 week follow-up. As we all can see, the vitreomacular traction is resolved, and there is improvement in the foveal contour and the edema. Now coming towards his follow-up visual assessment, as we can see, now he improved to 6/12 in the left eye. Now what is vitreomacular traction syndrome? Vitreomacular traction syndrome is a disorder of vitreoretinal interface characterized by an incomplete posterior vitreous detachment, an abnormally strong adherence of posterior hyaloid face to the macula, and anterior-posterior extend by the synergetic vitreous pulling at adherent sites on the macula, causing morphologic and often functional effects. The annual incidence of isolated VMT is 0.6 per 1 lakh population, and the prevalence of VMT syndrome is reported to be 22.5 per 1 lakh population. The prevalence and incidence of VMT associated with diabetic retinopathy, diabetic macular edema, age-related macular degeneration, and other macular diseases such as concurrent VMT is much higher. Now, what are the causes of vitreomacular traction? They are high myopia, age-related macular degeneration, diabetic eye diseases, and retinal vein occlusion. This is the International Vitreomacular Traction Study Group classification, which further divides it into vitreomacular adhesion, vitreomacular traction, and full thickness macular hole, which are further subclassified into focal or broad according to their size, isolated or concurrent with other disease, and no structural abnormalities in the retina in case of vitreomacular adhesion. But in the case of vitreomacular traction, there are some structural changes in the macula. And as for full thickness macular hole, they are small, medium, or large, with or without VMT, and primary or secondary to other conditions. This is the OCT picture showing difference between vitreomacular adhesion, vitreomacular traction, and full thickness macular hole. Here are some articles. This article of vitreomacular traction was published in 2012 with some conclusions. And this article, a review of current management of vitreomacular traction and macular hole, was published in 2015 with some conclusions. I'd like to thank you all.
Thank you, Dr. Akib. And next, I'd like to call Dr. Taha for the third presentation for today.
Assalamu alaikum, everyone. My name is Dr. Muhammad Taha Farooq. I'm a PGR in Ophthalmology Department in Gulab Devi Hospital. The case I'm going to present today is as follows. Patient XYZ, 11 years of age, male, resident of Lahore, student by occupation, presented to us through OPD with complaints of growth in left eye since childhood and irritation and watering on and off for past 6 months. On the history of presenting illness, the growth was located on the supratemporal orbital quadrant in the left eye. It was painless and increasing gradually from past 1 year. There was no history of trauma to the eye. The growth was associated with irritation and watering. There was no itching and no discharge in the eye. The right eye was normal. This was the growth, as we can see over here. It's in the left supratemporal quadrant. This is a limbus. So it's approximately 7 millimeters from the limbus. It was smooth and not adherent to the upper eyelid. His birth history was home birth. It was uneventful. His immunization was complete according to the EPS schedule, and he was on mother feed in childhood. There is no significant past surgical or medical history. He had two brothers and two sisters and belonged to a lower middle class family. On general physical examination, the patient was sitting comfortably, well oriented in time and place. His GIT was normal, CNS was also normal, and CVS and respiratory systems were normal as well. On ocular examination, his visual acuity was normal, 6 by 6 in both eyes. Eyelids were clear, the cornea was clear as well, and the pupil were round, reactive in both eyes. The anterior chamber was quiet and deep, the lens was clear, and extraocular muscle movements were full in all gazes. The intraocular pressure was 14 in the right eye and 13 in the left, and the fundus examination was normal as well. On further examination of the growth, it was a subconjunctival growth on supratemporal area under the upper eyelid, approximately 7 millimeters from the limbus. We were unable to appreciate the extent of the growth. There was mild conjunctival congestion. The growth was smooth and free from the upper eyelid, and the right eye was normal. On the basis of this history and these examinations, we can make the following differential diagnosis. It can either be dermolipoma or herniated orbital fat, lacrimal gland cyst, lacrimal gland prolapse, and conjunctival lymphoma. To further differentiate between the differentials, we performed following investigations: B scan of the left eye and the CT scan. On B scan, the report came that it was a homogeneous fat isogenic mass, dermolipoma, settling on the supratemporal part of the sclera. The sclera was normal on topographs, retrobulbar spaces with extraocular muscles were normal, and there was no sign of inflammation. This was the report of the B scan. We further went on CT scan, which was a little bit surprise for us because it was suggestive of left extraocular foreign body, which was metallic artifact at uvuscleral layer at temporal site causing inflammatory reaction. As I told previously, there was no history of any trauma, so this was a bit surprising for us. This is a report of the CT scan. Now our diagnosis was changed to left subconjunctival foreign body. First of all, we gave the medical treatment to the patient with a combination of antibiotic and steroid ointment for easement of his irritation and watering, and also for the mild conjunctival inflammation which he was having. And also we prescribed artificial tears to the patient. Surgical intervention after the medical intervention was planned 2 weeks after that. It was exploration and general anesthesia. As we can see over here, the suture was placed for anchoring, so we can better visualize the left supratemporal area. After periotomy, there was a blunt dissection being carried on with scissors, as you can see over here. Cautery was also used for further dissection. As we can see over here, the mass was identified and was being released from the underlying tissue of blunt dissection. Over here we can see that the mass is almost excised, and we can appreciate the bare sclera underneath. The mass has been excised. Now we placed continuous sutures of Vical 60 to close the wound, and Tennant's capsule and conjunctiva. We can see over here the sutures are placed and the wound is closed. Exploration under general anesthesia was done with aseptic measures. Granulation tissue was removed, the foreign body was recovered and sent for histopathology. The wound was sealed with continuous sutures. The histopathology, we discussed the histopathology with the histopathology department, and they said that the granulation tissue, which was encapsulating the foreign body, it contained fat as well as some bit of granulation tissue, and the foreign body was placed in acid medium to check whether it was containing any cartilaginous material or was it any other material. After placing it in acid medium for some time, it was not dissolved, so they concluded that it was of plastic origin and not of any cartilage or bony structure. This was the foreign body which was recovered, and this is the granulation tissue which was encapsulating it. On the first post-op day of examination, the conjunctival congestion was noted. There was no deposition or growth in the conjunctiva. The sutures were in place, and the extraocular muscle movement was full of the left eye in all cases. Any questions? Thank you. Thank you.
Ji. Thank you, Doctor. And I'd like to thank all three PGs for that wonderful presentations. We know how hard you guys worked on it. Next, I'd like to call our guest speaker, Dr. Sadaf. She is the consultant psychiatrist at Gulab Devi Hospital, and she would like to come up and please, ma'am, come up and give us your presentation.
Assalamu alaikum. My name is Dr. Rida Yaqub and I am FCPS psychiatry resident in Gulab Devi Hospital. So today we are here to discuss about the overlap between ophthalmology and psychiatry. This review will mostly be related to the congenital and inherited conditions. A number of congenital, inherited or acquired disorders present with both ophthalmic and psychiatric features. Thus, it is important for both ophthalmologists and psychiatrists to recognize early clinical features and comorbidities that would facilitate diagnosis and treatment of underlying issues. Studies have shown that vision and visual features. Studies have shown that vision and visual processing are altered in psychotic disorders. For example, eye movement alterations have been identified in individuals with schizophrenia and their siblings. Advances in brain and retinal imaging have allowed for careful and non-invasive investigations of these structures. For instance, lower retinal thickness, peripapillary ganglion cell layer, and retinal nerve fiber layer thickness have been reported in patients with schizophrenia and bipolar disorder. Patients with schizophrenia, moreover, thinning in primary visual cortex has been described using functional imaging in psychosis when compared to healthy controls. So the aim of this narrative review is to provide an overview of congenital and inherited diseases that present with ophthalmic and psychiatric features, while also highlighting the importance of multidisciplinary approach for the management of these patients. Now, I would like to request our consultant psychiatrist, Dr. Sadaf Humawakar, who is working as a senior registrar in psychiatry department of Gulab Devi Hospital, for detailed presentation and review of today's topic.
Thank you, Dr. Rida, for the very important introduction regarding the importance of liaison between departments. So, okay, so we're going to discuss regarding some craniofacial disorders in which ophthalmological and psychiatric manifestations occur. Noonan syndrome is a craniofacial abnormality in which there is a triad of some distinct facial features along with congenital heart disease and short stature. Some ophthalmological findings that we see in Noonan syndrome are hypertelorism, refractive errors, keratoconus, strabismus, nystagmus, among others. So basically, there are some abnormalities in the hippocampus in patients with Noonan syndrome along with prefrontal cortex. Due to these abnormalities, these patients are unable to concentrate properly. They do not have a good attention span. Because of this disturbance in attention span, they often have symptoms of ADHD, attention deficit hyperactivity syndrome. It may be a proper diagnosis, or it may be some specific symptoms may be present, and we need to manage them. Now, apart from ADHD, they may present anxiety syndromes with depressive symptoms, and they may have phobic anxiety disorders or panic attacks. The good thing is that mostly their IQ is within range, and due to this, it's easier to work with them. Behavioral modification works. If needed, pharmacotherapy is also used. And also we need to psychoeducate them regarding the illness, regarding the manifestation of the ophthalmological manifestation along with the psychiatric manifestations and social support. Down syndrome, trisomy 21, it has developmental delays, as we all know, along with some intellectual disability, cardiac problems, very distinct physical features are present. The ophthalmological findings in Down syndrome are strabismus, refractive errors, nystagmus, problems with accommodation. They may have keratoconus or optic nerve pathologies or glaucoma. There's a whole cluster of psychiatric manifestations that may occur in Down syndrome. They may present with mood disorders, with anxiety disorders, with psychotic disorders, or tics, impulse control disorder. Also, there's a very strong link between Down syndrome and Alzheimer's disease. Now, the diagnostic challenge with Down syndrome is intellectual disability. Because of intellectual disability, it becomes very hard to diagnose and treat the patients. And but once again, the good thing is that they usually present with mild to moderate intellectual disability. So still, some behavioral modification may be helpful. Some psychological testing may be administered, and we may be able to treat them on the psychological parameter too. Behavioral modification. If depressive symptoms are present, CBT may be used. We have to keep in mind their settings, their home settings. If they're going to a school or a training center, we have to keep in mind those centers, and we have to educate their teachers and their parents regarding the problems that the patient might face and how we can help them to deal with them. And pharmacotreatment may be used if required. We're going to talk about some retinal disorders. Retinitis pigmentosa and Usher syndrome. Okay, so retinitis pigmentosa is the most common inherited retinal disease. There is progressive degeneration of rods and cones. Eventually, the patients may have tunnel vision. And Usher disease has retinitis pigmentosa along with disturbances in hearing and disturbances in balance. So the ophthalmological features often seen in Usher syndrome are night blindness, peripheral vision loss, and there may be macular edema, and they may have optic nerve atrophy and pallor. The psychiatric presentations they may have obsessive compulsive symptoms. Roughly 40% of these patients may present with obsessive compulsive symptoms. They may present with symptoms of psychosis, of schizophrenia. They may have delusions of paranoia and auditory hallucinations. They may present with personality disorders. Now, when a very vital sensory organ is disturbed, it causes disturbances in multiple parameters. So it may result in aggressive outbursts. It may result in disturbances in personality. It may result in anxiety. So it's very important for us to realize that we really need to identify these psychiatric manifestations, and we really need to refer these patients where they're needed. Apart from that, they may have depressive symptoms. Mostly patients with retinitis pigmentosa, when they're assessed, they have depressive symptoms. They may present with bipolar disorder, depression, ADHD, conduct disorder. It's a whole cluster of symptoms that may present. They're managed via behavioral modification. It depends on the presentation. They might need counseling, they might need behavioral modification, they might need medical management. Suzak syndrome is an autoimmune disease in which there is a vasculopathy. The endothelial lining is destroyed of small vessels. Usually it affects retina and small vessels of the brain. They may present with encephalopathy and branched retinal artery occlusion and sensory neural hearing loss. These patients may present with cognitive impairment, dissociative symptoms, apathy, bipolar disorder, and personality changes. Norrie disease, it is an X-linked disorder. So it's X-linked recessive disorder. So usually you'd see them in males. And it has severe congenital impairment in vision, along with sensory neural hearing loss. And there are neuropsychiatric abnormalities. So the ophthalmological findings that can be seen are severe sight impairment, cataracts, nystagmus, retinal detachment, hemorrhages, they may be seen. These patients present with cognitive impairment. They may have behavioral symptoms, and what we need to keep in mind in Norrie disease is autism spectrum disorder. So we need to treat them on the lines of behavioral therapy. Cerebrotendinous xanthomatosis is a rare autosomal recessive disorder in which there is a lipid storage problem. So basically, cholesterol builds up in them and it starts depositing in multiple parts of the body. These patients may present with cataracts, xanthomas. They may have ocular changes. They may have nerve atrophy. They may have problems with the optic nerve. And these patients usually present with symptoms of psychosis. They may have hallucinations. They may have aggressive outbursts, sleep disturbances. Kearns-Sayre syndrome, it's a multisystemic genetic disorder. It's a neuromuscular condition in which there is there's a disturbance in the extraocular muscles. They have ophthalmoplegia. So these patients present with ptosis, diplopia. They have pigmentary retinopathy, corneal edema. And these patients may have psychiatric presentations such as bipolar disorder. They may have cognitive impairment. They may have psychosis. They may present with psychotic symptoms. And they may have symptoms of depression and PTSD. Wolfram syndrome, it's a neurodegenerative disorder, and it presents, it usually has diabetes insipidus, juvenile onset diabetes mellitus, and optic nerve atrophy, deafness, and urinary tract problems. In the psychiatric features, usually in 60% of the patients with Wolfram syndrome, they have 60% may present with psychosis. They may present with paranoid ideation. They may present with grandiose ideation. They may present with hallucinatory behavior or with aggressive outbursts. They may also present with thoughts of suicide because of multisystemic involvement. They may present with suicidal ideation because of severe depression. So once again, the treatment, it depends on the presentation of the symptoms. If the patient is presenting with psychotic symptoms, we'll need to give them antipsychotics. If the patient is presenting with severe depressive symptomatology, we might need to start them on cognitive behavioral therapy. We might need some antidepressants to manage the depressive symptomatology. Batten disease is a neurodegenerative pediatric disorder, and it's usually fatal. These patients usually do not survive past the age of 30. These patients have progressive visual and cognitive disturbances, seizures, and motor problems. In the ophthalmological features, they usually present with optic nerve atrophy, pigmentary retinopathy. They may have cataracts, glaucoma. And in the psychiatric presentation, they may present with features of anxiety, with restlessness, irritability. They may have inappropriate laugh. They may have personality abnormalities and hallucinatory behavior. And they may have sleep disturbances. Now, because this is a fatal disease, usual treatment is palliative, and anti-epileptics are usually used because they also have epileptic fits. So anti-epileptics are used, which also aid in their mood stabilizing properties, because these patients usually have disturbances in their mood, in the regulation of the mood. Low syndrome is an X-linked recessive disorder. So once again, it will be presenting more in males. It has a triad of congenital cataract, intellectual impairment, and proximal renal tubular dysfunction. The ophthalmological findings usually seen in these patients are congenital cataract, glaucoma, corneal scarring, and keloids. The psychiatric manifestation seen in these patients are obsessive compulsive symptoms, irritability and aggression, self-injurious behavior. They have stereotyped movements, and they have tantrums. And maladaptive behavior is seen in 41% of these patients. Now, because of the cognitive impairment, usually behavioral therapy is effective only to a certain limit, and medication is usually used to manage their symptoms. Antipsychotic medication may be needed, antidepressant may be needed if antidepressant symptomatology is present. So usually psychological interventions do not work over here. So antidepressants are used, stimulants are used, sedatives are used to manage the behavioral symptomatology. I would now like to call upon Dr. Rida to conclude the presentation.
Thank you very much, Dr. Sadaf, for this wonderful and informative session. There was quite a lot to learn from it. So the objective of today's presentation was to have a know-how about the genetic disorders showing both ophthalmologic and psychiatric manifestations and how to manage them through a multidisciplinary approach. Usually the patients and their family members, when presenting with such illnesses, do not recognize their psychiatric manifestations, for which it is important for the doctors to pick these manifestations and address them as well. So a good liaison with a psychiatry department and other departments is optimal for better management. I would like to thank you all for providing us with this opportunity, and thank you all for your precious time.
Thank you, Dr. Rida and Dr. Sadaf, for that wonderful presentation. Now I'd like to call upon Dr. Nasir Chaudhry Sahab once again, General Secretary, for the prize giving session.
Thank you very much, Dr. Faisal. First of all, I would like to thank once again Dr. Sadaf and Dr. Rida for a very well illuminated talk covering all aspects of behaviors, psychological issues related with the ophthalmic perspective. As we know, much is talked at the level of PMDC and WEFME to add different approaches like interprofessional communication, like interdisciplinary, multidisciplinary, transdisciplinary approaches in the curriculum. And the others like professionalism, empathy, and patient safety. सो अगर हम बात करें यूएचएस के लेवल पे तो यूएचएस में अभी बिहेवियर साइंसेस के 4th ईयर के लेवल पे ये साइकोलॉजिकल पर्सपेक्टिव वो उनके करिकुलम में ऑलरेडी एडेड है तो थैंक यू वेरी मच फॉर बीइंग विद अस and then we need to give big round of applause to Professor Dr. Mia Arshad Saab and Dr. Tahir Ghaffar for excellent presentations. और नाउ आई वुड लाइक टू क्योंकि डॉक्टर सारा जो है एक जो एक छोटा सा फीडबैक कि आई हैव बीन पार्ट ऑफ एंड आई हैव बीन मैनेजिंग रिसर्च मेथोडोलॉजी वर्कशॉप एंड कम्युनिकेशन स्किल वर्कशॉप ऑफ KEMU. प्रोफेसर Amira जो है she has been the backbone of teaching and training during her stay at KEMU and she is always missed और ये हमारा बड़ा vital part थी उस workshop का भी. Just a humble feedback इसमें जो क्वेश्चन पूछने के रेजिडेंट से नौबत इसलिए नहीं आई कि उन्होंने बड़ा इंटेलिजेंटली स्मार्टली प्ले किया प्रेजेंटेशन के साथ ही उन्होंने लिटरेचर रिव्यू भी ऐड कर दिया. नॉर्मली ये कि आपको जैसे तकरीबन 4 के करीब प्रेजेंटेशन होती हैं इसमें आपने comprehensive history, examination, differential, provisional diagnosis, management plan, and then उसका outcome और take home message. ठीक है तो that is what is required normally in these clinical case presentations. जस्ट मैं मैडम से बैठी हुई हैं तो इनका एक फीडबैक ले लेंगे कि जिस तरह रेजिडेंट ने एक्सीलेंट प्रेजेंटेशन थी और जिस तरह माशाल्लाह हमारे जजेस ने उसको मार्क किया इट वाज वेरी डिफिकल्ट कि उनको किस तरह सारे ऑलमोस्ट पैरेलल चल रहे थे. तो मैडम से रिक्वेस्ट करूंगा कि 1-2 मिनट के लिए सिर्फ इनको ये बता दें कि जब ड्यूरिंग प्रेजेंटेशन आई टू आई कॉन्टेक्ट और आपका कॉग्निटिव लोड आपने एक स्लाइड में कैसे मैनेज करना है, एक स्लाइड में नंबर ऑफ सेंटेंसेस वर्ड्स या उसमें इवन जो कलर आपका कंट्रास्ट है वो आपने कैसे मैनेज किया. तो जस्ट 1 मिनट में अगर आप दैट विल बी अ ग्रेट हेल्प इंडीड. इधर आ जाइए.
Bismillahirrahmanirrahim. बहुत शुक्रिया. Thank you very much, Dr. Nasir, for inviting us over here. जितनी भी प्रेजेंटेशन थी सारी प्रेजेंटेशंस बहुत अच्छी थी. आपने बहुत मेहनत की हुई है. किसी भी प्रेजेंटेशन में यू हैव टू लुक आफ्टर 2 ऑफ द स्किल्स. एक होता है जो आपका कॉग्निशन, मतलब आपने नॉलेज कितनी है, इट रिप्रेजेंट्स इन योर प्रेजेंटेशन. दूसरी चीज ये है कि हाउ टू प्रेजेंट. दोनों पोर्शंस में ये है कि जैसे डॉक्टर नासिर ने भी बताया 2 या 3 असूल हैं. असूल ये हैं कि इट शुड बी इन अ कंट्रास्ट कलर्स होने चाहिए. जैसे बैकग्राउंड अगर जो में ब्लैक है तो उसके ऊपर वाइट फॉन्ट यूज कर लीजिए, येलो भी चल जाता है, या डार्क ब्लू के ऊपर आप येलो फॉन्ट यूज कर लीजिए. اور دوسری بات جو بتاتے ہیں کہ دیکھیں یو ہیو ٹو کیٹر فار دی ڈاکٹرز یا فار یور کولیگز دیٹ آر سٹنگ ایٹ دی بیک. تو اس کا طریقہ کار کیا ہے کہ جو فونٹ کا سائز, ایک تو چیز ذہن میں رکھیے کہ فونٹ کا سائز جو ہے نا وہ سیمیٹریکل ہونا چاہیے ان آل دا سلائڈس. ٹاپک کا تھوڑا سا ڈفرنٹ ہو سکتا ہے اور جو باقی آپ کا کانٹینٹ ہے اس کا ایک جیسا ہونا چاہیے فونٹ. For one slide, it has to be the rule of 6x6 or 7x7. 6 lines and 6 words. Yes, 7 lines and 7 words. یہ سلائڈس ہونی چاہیے. دوسری بات یہ ہے کہ ہاؤ ٹو کیٹر فار دوز سٹنگ ایٹ دی بیک, کیونکہ پریزنٹیشن آپ یہاں پہ بھی کریں گے, لیکچرز میں بھی کریں گے, اینڈ یو ول بی پریزنٹنگ ان دی کانفرنسز. تو کانفرنسز کے ہال بہت بڑے ہوتے ہیں. ان کے لیے کیا طریقہ کار ہے, وہ یہ ہے کہ جو بھی فونٹ آپ بنائیے, ایک تو یہاں ڈیسک ٹاپ پہ آپ دیکھ رہے ہیں, پھر اس کے بعد یو اسٹینڈ ایٹ 2 میٹرز. اب 2 میٹر کا حساب کیا ہے کہ دس از 2/3 آف اے میٹر. تو آپ 2 ہاتھ جو ہے نا وہ پیچھے ہو جائیے اور دیکھیے کہ جس طرح کا فونٹ آپ کو نظر آ رہا ہے بیک سائڈ پہ بھی بالکل ویسے ہی نظر آ رہا ہوگا. دس ہیز ٹو ڈو ود اے ویژول اینگل, جو ہم ویژول ایکوٹی کرواتے ہیں ویژول اینگل پہ. تو 2 میٹر پہ کھڑے ہو کے دیکھیے کہ اگر آپ کا فونٹ جو آپ نے لگایا وہ آپ کو کلیئرلی نظر آ رہا ہے, اور تو پھر بیک والے کو بھی صحیح نظر آئے گا. دوسری بات یہ ہے ہر پریزنٹیشن میں one slide is for introduction, then your learning objectives کہ کیا ہم لرن کر رہے ہیں, اور پھر all your slides, then you have to time yourself. کیونکہ آپ کی جو presentations ہیں in the conferences وہ 7 to 8 minutes ہوتی ہیں, maximum 10. دوسری بات ہے اپنی slides جو presentation ہے اس کو نمبر لگا لیجئے. آخری 2 slides جو ہوتی ہیں, ایک میں summary ہوتی ہے of what you're presenting, ایک ٹیک ہوم میسج ہوتا ہے. اب سمری میں یہ بھی ہو سکتا ہے کہ جو آپ کے پریزنٹیشن ہے اس کے مین پوائنٹس وہ آپ لکھ لیں, یا دوسری چیز یہ ہے جیسے if you're presenting with a cataract, I'll talk simple. If you're presenting with a cataract کہ congenital cataract ہے تو آپ دونوں تصویریں لگائیے, congenital cataract کی اور جو آپ نے آپریٹ کیا وہ, تاکہ کمپیریزن ہو سکے. ٹیک سمری کی سلائیڈ اور ٹیک ہوم میسج. دوسری بات یہ ہے کہ when you stand here یا in any conference, موسٹ امپورٹنٹ تھنگ از یور اٹائر. آپ نے پہنا کیا ہوا ہے, بولڈ کلرز پہنیے یا سنگل کلرز پہنیے, ایسے کہ جو بہت زیادہ اٹریکٹ نہ کریں. دوسری بات یہ امپورٹنٹ ہے آئی کانٹیکٹ. آپ نے پریزنٹیشن یہاں پہ بھی چل رہی ہے, ادھر بھی ہے, لیکن یور آئی کانٹیکٹ ود دی آڈینس وہ بہت ضروری ہے. اور بیچ میں when you are presenting تھوڑا سا پاز لیجیے for your next slide to be, تھوڑا سا پاز لیجیے, ٹھیک ہے. اور جو سلائیڈز ہیں وہ اپنی پریکٹس کر لیجئے اتنی کہ آپ کو ورڈ ٹو ورڈ نہ پڑھنی پڑے. یو شوڈ ہیو آئی کانٹیکٹ ود یور آڈینس, اور پریکٹس کریں. جتنا پریکٹس کریں گے اتنا آپ کا ٹائم کا جو ہے وہ آپ ٹائم اچھا مینج کر سکیں گے. دیز آر سمپل اسٹیپس, جو ٹپس جو ہم وہاں ٹیچ کرتے تھے کنگ ایڈورڈ میڈیکل یونیورسٹی میں, جو کمیونیکیشن سکلز کی ورکشاپس تھی, تو وہاں ہم پاور پوائنٹ کی پریزنٹیشن اسٹوڈنٹ سے کراتے تھے. کیونکہ وی بینگ ڈاکٹرز, you being you'll be consultants, and so you'll be presenting all your life. These are the simple steps جو کہ آپ پریکٹس کرتے رہیں تو آپ بہتر ہو جائیں گے انشاءاللہ. تھینک یو ویری مچ, بہت شکریہ.
Thank you very much, madam, for your valuable words. One of my motivation جو میں نے جو میڈیکل ایجوکیشن کی, کیونکہ کئی میں ٹف روٹین ہوتی ہے, اور اس ٹف روٹین کے ساتھ میرا ایک پیشن ہے پرسنل کہ میں چیریٹیبل سروسز میں انڈر پریولیجڈ ایریا میں انوالوڈ ہوں, ہیویلی انوالوڈ ہوں. اس کے ساتھ جب میں نے میڈیکل ایجوکیشن کی تو ون آف دا موٹیویشن واز میڈم تھی. تو انہوں نے کہا جی کہ آپ میڈیکل ایجوکیشن کریں تو بندہ جو ہے میڈیکل ایجوکیشن بندہ ایک انسان بن جاتا ہے. تو وہ بڑا ایک میموریبل, اور بلکہ میں نے جب میرا انٹرویو ہوا تھا تو میں نے بتایا جی کہ یہ موٹیویشن تھی اور اس وجہ سے میں انسان بننا چاہتا ہوں. تو بہرحال اب کیونکہ ڈاکٹر سارا شی از اسسٹنٹ پروفیسر ایٹ علامہ اقبال میڈیکل کالج, ایگزیکٹو ممبر ہے ہماری شروع سے, کیونکہ اس میں موجود تھی, تو میں ان سے ریکویسٹ کروں گا کہ جو فرسٹ 3 پریزنٹرز ہیں ان کو اناؤنس کر دیں.
السلام علیکم. پریزنٹیشنز ور ویری گڈ, بہت مزہ آیا. جیسے سر ارشد کی پرسنالٹی ہے, سافٹ سی اور
مزیدار سی, پریزنٹرز بھی ویسے تھے, سارے آرام سے بڑے مزیدار طریقے سے انہوں نے پریزنٹ کیا, ہم نے بڑا انجوائے کیا سر, تھینک یو سو مچ. آپ نے بڑی ایفرٹ کی ڈیفینیٹلی اسٹوڈنٹس کے ساتھ. ساری پریزنٹیشنز بہت اچھی تھیں. میڈم سائیکائٹری کی بھی بہت اچھی تھی. ایک آن دا لائٹر نوٹ آپ سے ایک تھوڑا سا کوشچن بھی میں نے ذہن میں آ رہا تھا کہ میڈم آپ ذرا یہ بھی بتائیں کہ اگر آپتھمولوجسٹ اسٹریس میں آ جائیں یا ڈپریشن میں آ جائیں یا ہائی لیول والی سرجری ہو تو اس کو کیسے ڈیل کرنا ہے, وہ بھی آپ نے ہمیں تھوڑا سا بتانا ہے. مائک میڈم آپ کے پاس ہے, تھوڑا سا آپ وہ بھی بتائیں اس کو کیسے ڈیل کریں, ہمارے ریزیڈنٹس بھی کنسلٹنٹس بھی.
تو یہ پرابلم صرف آپ کے ساتھ نہیں, یہ ہر کسی کے ساتھ ہوتا ہے. whenever we are dealing with a stressful situation, there are times when we get overwhelmed, اور اس کے لیے the easiest way is کہ آپ اس وقت deep breathing exercises practice کریں, because basically when you hyperventilate تو وہ tremors and everything that happens because of that. تو آپ نے اس وقت اپنے آپ کو ریلیکس کرنے کے لیے ایک تو ڈیپ بریدنگ ایکسرسائزز کرنی ہوتی ہے, اینڈ دین دیر از اے ٹیکنیک کال پروگریسو مسل ریلیکسیشن. یو کین ایزیلی فائنڈ دیٹ آن یوٹیوب. اس سے آپ کی ایموشنل ریگولیشن اچھی ہو جاتی ہے اور انگزائٹی انڈر کنٹرول رہتی ہے. سو یو کین ایون ٹرائی اٹ وین ایور یور, مطلب آپ اسکربڈ ان ہے, سرجری کرنی ہے اور آپ بہت اینکشیس ہیں, ڈیپ بریتھ ان لیں, ہولڈ اٹ, کاؤنٹ ٹو 10 ان یور ہیڈ اینڈ دین بریتھ آؤٹ تھرو یور ماؤتھ. تو آپ اسی وقت ریلیکس ہو جائیں گے 5 to 10 breaths.
دیکھیں کتنی بڑی لرننگ ہے ہم سب کے لیے, ٹھیک ہے, اسٹوڈنٹس کے لیے بھی, ایگزام سے پہلے بھی. Okay, the first, second, third positions. The first position goes to Dr. Taha Farooq for a very good presentation and a rare case. The second position goes to Dr. Hafiz Akib Ardalan, and third is Dr. Binte Zahra.
تھینک یو ویری مچ ڈاکٹر سارا. پروفیسر حامد بٹ صاحب ہمارے لیے ایک جو میڈیکل ایجوکیشن میں کرنٹ پرسپیکٹو اگر ٹیچنگ اور ٹریننگ کی بات کریں, ایک تو وی آر گریٹفل کہ یہ ہر کلینکل میٹنگ میں ہوتے ہیں, اور ابھی ہمارا انشاءاللہ پلان ہے ان اے ویری نیئر فیوچر کہ ہم نے انسٹیٹیوشنل لیول پہ ہر انسٹیٹیوشن میں اور او ایس پی کے تھرو پلیٹ فارم تھرو کلینکل میٹنگز میں ہم نے کچھ سیشنز ان سے ریکویسٹ کرنی ہے کہ جس میں فارمیٹیو اسسمنٹ کی جو ٹول ہے منی سی ایکس اور ڈاپس ان کی امپلیمنٹیشن ان لیٹر اینڈ اسپرٹ, تو اس کے لیے ہم ریکویسٹ کریں گے. تو ابھی جو ہے میں سر سے پروفیسر حامد بٹ صاحب سے پروفیسر سلیم اختر صاحب سے ریکویسٹ کروں گا, اور سر ارشد صاحب بیٹھے ہوئے ہیں سوشل سیکورٹی سے, یہ آئیں اور جو ہمارے جو پریزنٹرز تھے ان کو شیلڈ اور کیش پرائز اور سرٹیفکیٹ دیں. آ جائیں سر. اور میاں ارشد صاحب بھی, سر آپ آ جائیں. میاں ارشد صاحب بڑے ہمبل انسان ہیں, ہمارے جوائنٹ سیکرٹری بھی ہیں اور ہماری او ایس پی کی بیک بون ہے ماشاء اللہ. آ جائیں سر. اب اگر پریزنٹرز کی بات کریں تو پہلے جو ہمارے جو آپتھلمالوجی کے ریزیڈنٹس تھے, بنت زہرا جو تھرڈ پوزیشن ہے جن کی, ان کی شیلڈ اور سرٹیفکیٹ. فیصل ان کی شیلڈ ان کو بلا فلانا. اور جو سیکنڈ ہے ہمارے
جی سیکنڈ جو عاقب ہے, ڈاکٹر عاقب. عاقب
کیش پرائز. اچھا, اور فرسٹ ہے
اینڈ فرسٹ ڈاکٹر طاہا.
جو ہمارے جو تینوں پوزیشن ہولڈرز ہیں ان کو سرٹیفکیٹ اور شیلڈز کے علاوہ, سر آپ بھی آ جائیں اور فہد آپ بھی آ جائیں, اور ان کو ہم کیش پرائز بھی دیتے ہوتے ہیں. تو تھرڈ پوزیشن کے لیے بنت زہرا. یہ تھرڈ پوزیشن کے لیے, یہ تھرڈ پوزیشن. جو سیکنڈ پوزیشن ہے جو کیش پرائز ہے سیکنڈ پوزیشن کے لیے, یہ فرسٹ پوزیشن کے لیے. میڈم میرا آپ بھی جوائن کر لیں. اچھا اب میں ریکویسٹ کروں گا ڈاکٹر صدف سے کہ وہ آئیں اور ان کو بھی شیلڈ پیش کریں گے. آج آپ بھی ساتھ آ جائیں. سارا اب میں ریکویسٹ کروں گا اپنے جو وردی ٹیچر ہیں پروفیسر سلیم اختر صاحب اور احمد بٹ صاحب سے کہ ہمارے جو چیئرمین ڈپارٹمنٹ آف سلمالوجی علیم میڈیکل کالج ہماری او ایس پی کے جوائنٹ سیکرٹری بھی ہیں میاں ارشد صاحب کو ایکسیلنٹ ارینجمنٹ فار دا کلینکل میٹنگ ان کے لیے فلاورز پیش کر دیں. ایک بوکے ہم نے پیش کرنا ہے ڈاکٹر طاہر جو اسسٹنٹ پروفیسر ہیں ان کے بیٹے نے آج انہوں نے ماشاء اللہ حفظ بھی کیا ان کے بیٹے نے تو ایک